welcome to the second Global Spine Surgery Seminar. A few people are still coming into the session, and so we'll give everyone a few seconds to come in. We can go ahead and get started. So today's session is on early onset scoliosis. Thank you again to everyone who joined our session last week on failed back surgery syndrome. We're very excited for this case discussion today. In terms of using Zoom, a few housekeeping things. If everyone can keep themselves on mute, unless you're presenting, that would be awesome. Second, we can do show captions. You can click the button on your Zoom sort of window screen, and then you can choose the caption language to select your language of choice. If you'd like to if you'd like to engage in the conversation, feel free to just use the raise your hand function so we can see you, or type your question in the chat and we'll be monitoring those as well. In terms of the resources we have available, all of our pre-work sessions were on the SONA Global Academy website. It's a great resource. It also has all the videos the live sessions recorded will be available on those as well. For this session in particular, we had a number of articles and videos that some of our faculty recorded beforehand. So if you haven't had a chance to check that out, would really encourage you guys to do that at the close of this session. They're really great videos and lectures. In terms of course objectives today, primarily improving knowledge of complex spine pathology and management. Two, we want to foster international discussion, provide practical advice to surgeons, anesthesiologists, physiatrists in resource-limited settings. And as always, we'd love to motivate and support the younger generation of providers globally. Here is our intro slide. Course chair, Dr. Kieran Agarwal Harding from the Beth Israel Deaconess Medical Center here at Harvard. Kieran's been great. We're excited to have him here with all of his expertise as always. My name is Zenaida. I'm one of the current PGY4 residents going into spine surgery. I'm very excited to be here. I'll let Dr. Cohen introduce herself.
I'm Lara, another one of the PGY5s at Harvard, going into pediatric orthopedic fellowship to focus on spine.
We're going to be moving the session along. If you guys have any questions, again, let us know in the chat. None of this would be possible. Oh no, go back, Samhita. None of this would be possible without the amazing HGOC and SONA organizing team. Thank you guys for all of your tireless work, putting together all the sessions, getting the videos up. Wouldn't be able to do any of this without you guys, so very grateful. Thank you. In terms of our case presenters today, we have four incredible presenters here with us today. Our first presenter, Dr. Mateos Defino, coming from the hospital clinics of USP. Our second presenter, Dr. Yahia Bramboli, here from Zagazig University. He's a pediatric orthopedic surgeon. Our third presenter, Dr. Mohammed Fahim. He's an orthopedic resident from the Gurki Trust Teaching Hospital. And then lastly, we have Dr. Koja Yankee here from Focus Orthopedic Hospital. We have presenters from all over the world. We're excited to see what everyone is doing to manage early onset scoliosis from their parts of the world. So very excited. In terms of faculty discussants, we have four discussants joining us who will be providing their input on some of the case discussions as we go along. First, we have Dr. Ala Ahmed. He's a pediatric orthopedic surgeon from Palestine Polytechnic University. We have Dr. Ujwal Debnath, an orthopedic spine surgeon from the Gupta Institute of Medical Sciences and Hospital. We have Dr. Craig Eberson joining us he's a pediatric orthopedic surgeon as well, from the Hasbro Children's Hospital associated with Brown. And then we have Dr. Abdullah Shah. He's a pediatric orthopedic surgeon joining us from the Gurki Trust Teaching Hospital. Thank you all for dedicating your time. We're very excited for this session and to get started. And without further ado, we're going to jump in with Dr. Defino's case.
Hello, good morning. Thank you, Zenaida. I'm going to share my screen.
Lovely.
Can you see?
Yes, we can see your screen.
Okay, perfect. So the first case we are going to discuss is a patient with syndromic early onset scoliosis with congenital anomalies. First of all, I would like to thank you, the Harvard Global Orthopedic Collaborative, the SONA Global Academy, and also my friend, Dr. Rafael Sugino, for this invitation, the opportunity to share this kind of discussion. I'm Matheus Defino. I'm from Brazil. I live in São Paulo in a country seat called Ribeirão Preto. I work in the Hospital of Clinics, as you can see in the picture. It's inside the University of São Paulo. And so let's start with the case. This is a really interesting case. It raised big challenges, and I believe it's going to be a really interesting discussion. So the patient was 12 years old at the year of the treatment. It was 2024. She's diagnosed with syndromic early onset scoliosis associated to congenital anomalies. She had bilateral upper limb amylia, bilateral congenital short femur, associated to pelvic oblique caused by a left hip dislocation. So, talking about the case, you can see there is a severe coronal malalignment. The patient has a big pelvic obliquity, and I believe that the deformity started really early because of this compensatory curve caused for the need of the patient to have this view of the horizon. So it developed a big thoracic deformity associated to a proximal cervical deformity. We did some initial X-rays without traction and with traction, and we could see there was a bit of flexibility, but the curve was really stiff. This is the sagittal image of the patient. We can see there's a high kyphosis, so we could classify this kyphoscoliosis. And as you can see in this view, there is a really three-dimensional curve, and so let's talk about the patient itself. The patient had no neurological deficits, had no pulmonary symptoms. She was non-ambulatory because of the hip problems, but highly functional using feet for daily activities such as self-feeding or writing. She has had a progressive difficulty with sitting balance and a significant parental concern regarding the deformity of this progression of this deformity. So I told Kieran that I would bring some topics to discussion, and I don't know if you want to discuss it now or in the end, but I would bring the questions. What defines success in this patient? Because as you can see, the patient, it depends a lot on her neurological function for daily activities, and how would deformity correction injure this? So would you perform surgery before? Well, as I told, the patient had an early onset scoliosis. This first picture, she had 10 years old. And as you can see, it really progressed. So it's a big challenge. And I will continue with the presentation. We can discuss this in the end, maybe. So we decided to start the management with a staged treatment. We started with halo gravity traction. Patient was submitted to this kind of treatment for 2 months. We couldn't see a big improvement in the clinical outcomes. Also, in the radiographic outcomes, we could see that there was not really a good flexibility. But that's another discussion that we can talk about, the role of allogravity traction in severe rigid deformities. In this case, we decide to do this preoperative, most because of the protection of this kind of neurologic function to stretch a spinal cord. So this is preoperative planning. As you can see, there's a high cope angle from T5 to L1, 146 degrees, with an apex at T9, T10, also with this cervical compensatory curve, and with a high pelvic obliquity with a 19 degrees angle. First surgery performed in the patient was in November 2024. We did a definitive fixation from T1 to pelvis. We included the pelvis most because of this pelvic obliquity. And we were really upset if this kind of construction would limit the mobility the patient had before. Because as I told you, she could self-feed, write, do makeup, and we were really afraid. And surprisingly, the patient with the time could maintain all of these functions. Also, we were really upset about the neurological injury. So we decided with a strategy to do some kind of bipolar construct with alternative fixations, including hooks, pedicle screws, and also, as you can see here, down on the level of 212, the use of sublaminar wiring. So intraoperative, we could see that this patient had a really stiff curve. It was really hard to obtain a total correction. And we decided to abort the sublaminar wiring strategy. We did only one, as you can see. And this is the evolution. So some questions I would like to bring for discussion. Would you prefer osteotomies? Would you accept this residual deformity? How would manage this pelvic obliquity, UIV strategy, alternative techniques for fixation, and how to reduce complication rates? Because as you can see, 1 month post-operative, the proximal hooks, we did a claw on the lamina. It had some kind of failure. We had a lamina fracture, and the hooks they had loosened. So patient was submitted to a revision surgery. We we tried to bend more the proximal rod, and we tried again to get some hooks, but the bone of the patient was really fragile. We had intraoperative fracture again, so we decided for pedicle screw fixation, and this is the final result. Here, 2 years follow-up, maintaining the same correction. Patient had in the early post-operative some kind of pain in the cervical thoracic transition, but at the long term, she developed well, and now she has no complaints. We were a bit upset about this kind of straight rod in the proximal curve, so we did CT scan to check if it was okay, and we can see there is a huge ankylosing process. So no pain. The patient is really good nowadays. As I told, it was really challenging because of the complications, the long time the patient stayed with the halo gravity traction, and now we are really happy that she has this kind of alignment that is necessary for her quality of life, and also she can still do the same activities as she did before. This is the clinical result. And as you can see, the three-dimensional curve, it has a residual deformity. But that was not our main goal in the treatment. We were really satisfied with the final result. And this is the evaluation of the radiographic. So this is the case. I brought you some topics for discussion, and I will let them here. Thank you so much.
Great presentation. I think if you want to keep the slide with the questions up, those are some great talking points. I
Okay.
think a really challenging case, not your standard EOS that demonstrates probably a lot of issues other people are seeing, and definitely something we saw throughout the other cases. Um, I think, we can start with question one, what defines success for this patient? I think you raised a lot of good points. I think especially in a patient with upper extremity phocomelia, the thing you're focusing on is retaining her ability to participate in activities of daily living, which requires lower extremity function. And so I think the right decision was made to try to prioritize neurologic safety. I'm not sure if people have other opinions on kind of having these conversations with family. And I know a lot of times at our pediatric hospitals here, we'll have a balanced conversation with the family about the decision whether or not to do osteotomies and the risk that comes with that. I think in this patient, you guys made the right call.
Thank you, Lara. It was really hard to decide, but the patient had not really big complaints because of her deformity. it was most apparent or concern about the progression. The complaint of the patient was kind of related to pelvic obliquity, but as I told you, she was really adapted. So it was challenge to decide on the surgery. And I do believe that we made the right choice. And I would like to discuss maybe something about the surgical strategy. Do you want me to return to the slide?
That would be great, Matheus.
So, first point of discussion that we had is the age of the treatment. We know there is a lot of long development, spinal cord risk. So we decided to keep the patient with a conservative treatment. Would you uh, do surgery before? Would you wait for the evaluation? What's your opinion about the time that the surgery has been executed?
What
You
age
have
should the patient?
sorry,
Yeah,
Yahia, go ahead. You have
Yeah,
after.
she was 10 years old at 2022 and 12 years old at 2024.
Yahia, go ahead.
Yeah, so for that question, first of all, nice presentation, extremely challenging case. But speaking retrospectively, it's always better to get the curve under control as early as you can. If you can, especially in low resource setting, if you can get that, it's much better than wait until the patient is skeletally mature, then attack it. So if you could attack that curve when it was like when she was 9 or 10 years of age, it would be a little bit easier, and you would have done the same thing, spinal fusion, with a little bit better result, less complication rate. So definitely the age of the patient is not the, the limiting factor. The limiting factor is the magnitude of the curve and how much it's progressing. So that is something hard to get, but it's the most important thing is not to allow the curve to progress to that point. Because if the idea of delaying surgery is to do a definite fusion at a larger age, so the patient has more thoracic height. But if the curve is progressing that much, they will not get any benefit from that thoracic height because it's not non-functioning. So excellent case, but if you could have done that a couple of years earlier, you could have gotten a little bit better result. Yeah, definitely.
Thank you, doctor. We have the same impression. Yeah. So I would like to discuss now about halo gravity traction. We decided to do this kind of treatment for most spinal cord protection, and also to check if there was some kind of flexibility that would favor in the final surgery. Do you have any comments, anything to add?
I know Dr. Eberson has his hand up.
So I would echo the excellent case presentation, very challenging case. I think halo gravity traction has a tremendous role, and it really does a lot of the work for you, and sometimes clarifies your plan. Can you talk a little bit about your particular technique in this patient, how many pins you used, what your traction setup, what your weight goal and time goal was?
Okay. So we used 4 pins. Nowadays, we would use 6. We didn't have complications with Halo itself, but if for children, it would be more recommended to have 6 pins, most 2 in the backside and sorry, 4 in the backside and 2 in the front. In ways of progression of the weight, we could set a goal like 40% of the patient kilo, and we can progress it daily. What I did in this case, we had a big bottle of water, and we every day we could like spend some 200 milliliters with a cup inside the bottle. So we could have a small progression of the weight, and we could have more acceptance of the patient. Because if you put like 1 kilo for 3 days, and then you wait 4 days to put 1 more kilogram, that may cause like impact. And this way, I would like to share with you, it was really interesting and it worked really well. Even if the traction didn't result in a good clinical outcome, I believe it had an important role and would be not recommended to do surgery in this patient without traction before.
Yeah, I would agree. We used to use weight. We switched to the spring traction scale, which I think was developed at Focus Hospitals. It's very easy to manipulate. We shoot for 75% of the patient's body weight for at least 8 hours a day, it's surprising for a curve this side to get very little correction. I would have thought, you can usually anticipate more. So a lot of times it's if you lay out ahead of time that the patient may be on traction, for more than just a couple of weeks, but even a month or two, you can get a benefit from that. I would also agree. I think if you're going to do prolonged traction, I almost always will do 2 pins in the front and 2 pins in the back on each side, even for an older kid, because if you do have a pin infection or a loosening, you can remove a pin without having to abandon your traction setup. The other thing, did you consider any sort of intraoperative traction?
Yes, we did intraoperative extraction for the pelvic oblique correction. So we did it on the left foot.
Left foot. So
Yeah,
another option, which I've used, we do some work in Honduras where we don't really have access to traction setups, is you can put a couple hooks around the ribs and a pelvic hook or a screw low and do intraoperative kind of stage track, and that can actually really help balance things out.
yeah.
And then I guess one last comment. I think your approach was excellent, and I think your goals were achieved. Sometimes when the osteoporosis affects the lamina, putting a few anchors around the ribs as well, and even linking them so you'd have almost 4 rods up at the top, will make your implant much stronger on the top if you don't feel that you have access to the pedicles.
Perfect, doctor. Thank you.
But really great case.
Thank you. So I'll start discussion now about the surgical strategy. This is our result, and I would like to make questions. Would you do something different? Do you have any concerns? I have some. I'll criticize. We could have bent more the rods in the upper portion. So I think this caused a bit of stress, and we know that the bone of the patient had a low quality, so this leads to this kind of event. But maybe even inside surgery, it's not possible to do this kind of bending. And I would like to hear from you. What are your comments?
Dr.
Dr.
Ahmad?
Abne.
Uh, Thank you very much for sharing this case. It's a very hard case, actually, whatever you would do, and the results are very good. Though I want to talk about the bipolar. Actually, the bipolar, the main indication for it, and in the literature, it's nearly always neuromuscular disorders that are flexible. Your case is not like that. It's a very rigid curve and very big curve, and it's not a neuromuscular kind of scoliosis that the bipolar would fit in. And also, biomechanically speaking, if you talk, the bipolar is having this passive like of elongation with this severe curve. And biomechanically speaking, if you have the 2 rods are on the concave side and very far from the apex, it will not have a very good effect on the correction of the spine. And also you'll have a high impact on the proximal anchors that will dislodge them, especially that you are having, I think, osteoporotic spine and these kind of things. So I might say that if I would have this case, my first choice would not be the bipolar. It either would be just putting distraction rods like traditional growing rods or magic rods. To do distraction, I mean to do active distraction, to get the apex to be to control a little bit, or which is my preference, to control the apex to have to go with the geometry, though it's hard for this case, to be honest. But to put a couple of screws in the apex and connect them with the proximal and the distal anchors, at least it will go with the geometry of the spine, and it will decrease the stress on the proximal and distal anchors, and will get some medialization of the apex of the curve, which will be much better, I think. This is what I say.
Thank you, doctor.
I think
I
you
would like,
raised another good point about pelvic obliquity, and I think that makes for an interesting conversation in a patient that has syndromic or congenital scoliosis, but not something like myelomeningocele where they have sensory deficits. And I'd love to hear from the panel, how big of a focus they have on fixing pelvic obliquity in a child who is sensate and maybe more aware and able to readjust themselves in a wheelchair and that sort of thing.
Allah, do you have any thoughts on that comment about the pelvic obliquity piece?
Well, for the pelvic obliquity, usually we talk especially about neuromuscular scoliosis, that in general, I mean. But for this case, definitely, I think we should go to the pelvis for this child for the pelvic obliquity, because I think it's a rigid one, rigid curve, having severe pelvic obliquity. And for this child, it's not like the thing that she's an ambulatory child. All what we need is to get her to be compensated by sitting. And I think what he has done here was right, to put screws in the pelvic region and to correct the pelvic obliquity.
Forgive my perhaps ignorant question here, but with a rigid deformity like this one, I think Mateus raised this question earlier. Is there a role for osteotomies for getting the pelvic obliquity right, for trying to reduce the deformity?
Well, the main curve, the major curve, is thoracolumbar curve, and the pelvic obliquity is severe for this case, and you can see even the preoperative sitting position of the patient. You can see that the pelvis is really, you can see the angle, pelvic angle. It's huge. I don't think, otherwise you'll do osteotomy at all levels, and but I'm not sure that you'll have a good result. The osteotomy might help to correct the curve, but I think you should go to the pelvis.
And just to clarify, the purpose of performing the like for getting the pelvic obliquity right, is it just allows the child to sit better and
Yes,
prevents pressure ulcers? Is that right?
yes, for sure. And because of that, I'm saying that we need to correct the pelvic obliquity. I don't think that osteotomy will correct it, and this is the thing that I'm talking about.
Thanks, Allah. Sorry for my ignorant question. Prof.
No,
Ujwal,
no,
do you have
no.
a comment?
Actually, maybe you're right. Maybe I'm wrong. So maybe Ujwal can he raise his hand.
Ujwal, you're muted.
Okay, can you hear me?
Yes.
Okay. I think I congratulate the team to have performed such a huge, technically difficult case with so many abnormalities in this early onset type of scoliosis. She is 12 years, as you said, when she underwent surgery.
yes.
12 years, right. So my first thing is, if we had not progressed to this stage, we might have had a better correction. That was first spoken by the other surgeons. Anyway, what the question is now is osteotomy and pelvic obliquity. So osteotomy here, what level of osteotomy you will do? Because the patient has good pulmonary reserve, has got good nutritional status, and all those things may affect the surgical outcome. You see, the osteotomy requires a lot of effort in getting the blood loss in control in these patients. So, see, looking at the size of the patient is small, the blood volume may be not enough for more than a couple of osteotomies. So now, if you want to do osteotomies, at what level would you do the osteotomies? So if you do the osteotomy at the level of L45, L5S1, then you may be able to correct the pelvic obliquity, and that would be beneficial to the patient's sitting position. So sitting would be more, as you've done the surgery, her sitting balance is still not quite good. I can see from the X-ray, but physically you may be better off by saying that, well, we have a good clinical photo where she is sitting all right and able to get good care of nursing. So here my thought would be because the pelvic obliquity after doing the pelvic fixation is still more than 25 to 30 degrees, if I can say that. So our role is to reduce the pelvic obliquity below 20 degrees. And if we do the osteotomy that at those level, lower lumbar level, L5 and L4, then we might be able to close on the pelvic obliquity a bit more. So this is my thought on the process of reducing the pelvic obliquity by doing osteotomy at lower lumbar levels. And doing osteotomy at a higher level in the mid-thoracic and other region is not devoid of huge complications in this case. And unless you want to do anterior surgery by doing discectomy at multiple levels, 6, 7 levels, then you have a chance of getting the correction of the apex more towards the midline, which Dr. Allah has already suggested. And that would have been effective in correcting the deformity much, much better. I think you've got already corrected more than 40% of the 50% deformity from 146. What would be the current curve angle? Would be around 70, 75 degrees. So you've done a good job. But if she had done we started this surgical decision making 2, 3 years earlier, then she would have done better off with the growth rods, and especially with Dr. Ala's technique, it might have been more beneficial. And you can do the osteotomies at a later date in 2, 3 years' time to correct the pelvic obliquity and redo the technique again. Is a it's kind of a final fusion you've done, so which we could have done at a later stage by 12, 13, whatever you've done is quite good. So pelvic obliquity could have been taken care of by doing a little bit of osteotomy. That's my say in the procedures. Thank you.
Thank you, doctor. So another thing that I would like to talk about is about the alternative fixation techniques that we utilize. So we did a lot of instrumentation, as you can see, with hooks. We tried for different kind of implants. And one consideration that I have is that if we had available technology for this case, for example, navigation, we could have insisted more in a higher density of pedicle screws, and maybe we could have made lower the stress on the proximal rods. This is some kind of consideration, but as we are here, there are sometimes resources are not available, and I think this was the solution that we made to this case. To minimize complications, I would suggest to bend the rod in kyphosis in the upper proximal portion, the maximum that you can. Okay. So if you have any considerations, we can talk more. I thank you everyone for the opportunity.
Great job. There's one question in the chat, and then I think we'll move on to the next case. The question is how to clinically decide the time of deformity correction to get best correction for congenital scoliosis in general. We can focus on this throughout. I think the main theme here is intervening on these children as early as possible, and so Obviously, the difference between age 10 and age 12 in this patient isn't significant, but I think as we go throughout the cases, we'll talk more about patients presenting at an earlier age and even buying time with bracing or casting or those sort of techniques before progressing to surgery.
Yeah, we didn't do anything in this case, but even nowadays we would try to do some kind of casting treatment. We know that there are a lot of good results regarding this, and I think it could have helped to manage deformity because most of the deformity of this patient was caused by a compensatory curve because of the need of the patient for the view of the horizon. So I believe those conservative strategies would also have helped the patient. But even everyone has the kind of situation. The patient came to us with a late appointment. So she came for us with 10 years old. So we lost this opportunity.
I think as Dr. Yahia pulls up his slides, maybe I'll just, from my layperson perspective, give an interesting one last comment that I found very interesting is sort of balancing the functional demands of the patient and wanting perhaps as a surgeon to get a really good correction, but making sure that you don't cause a neurologic deficit in this patient. Because obviously she doesn't have arms, she only has legs, and I'm assuming she's using the legs for most of her functional activities. So how devastating would it be if you're trying to chase a good correction with osteotomies and, aggressively correcting her curve and then cause a terrible neurologic deficit, which puts her in a much worse situation. So, Mateus, that was certainly a learning point that I'll take away from this case, and I appreciate that.
Thank you so much. So I'll finish my presentation. I would like to thank everyone, and we can go on with the discussion.
Thanks, Mateus. Dr. Yahia, you have your slides up. Please go ahead.
Okay. So first of all, thanks for the organizing committee for the tremendous effort they're doing. It's an excellent meeting. And thanks to Dr. Ala for the nice invitation. And so I'll be speaking about PGF in a 5 years old. So this is a 5 years old male patient that had progressed significantly over the last year. His deformity has progressed a lot. He has been complaining, the main complaint is difficult breathing. He has a history of multiple hospitalization for chest infection, at least once per month. Every time we'll spend about 3 to 4 days in the hospital because of recurrent chest infection. He's quite small for his age. He's 5 years of age, but he's like around a 3.5 or 3 patient. So this is his clinical photo. As you can see, he is very small. He has severe proximal thoracic kyphosis with the scoliosis. So to outline the problem, this is a patient with a progressive spinal deformity with a very small anatomy. And this deformity has increased a lot over the last year. He has severe restrictive lung disease. We cannot really even do a pulmonary function test for him because he is small size and it's worsening with time. He has a very severe proximal thoracic kyphosis, which is very hard to manage and increases the neurological risk. And we're not really sure whether it's a congenital anomaly or just a syndromatic. So then we requested a CT scan. You can find here the 3D model. The 3D model illustrated that it is not a congenital anomaly. There is no failure of formation, no failure of segmentation. It's just so widget from the long-standing deformity that it looks like a congenital anomaly. If you can see here, you'll find a severe proximal kyphosis. The spine is quite bent over itself. So, so what are our surgical goals? One, we need to control that spinal deformity. We need to improve the chest function because it's quite deteriorating. And he's very young, very small, so we need to allow spine growth. And we have a huge risk from the surgical point of view and anesthesia as well. So we need to lessen that as much as you can. I had the privilege to listen to Dr. Abdullah Shahin multiple presentation about their adjustment of the halopelvic traction technique done in Pakistan. So this was my first time to start doing that technique, to be able to do that patient. So we applied the halopelvic traction on an outpatient basis. So the patient went in the hospital, did the halopelvic traction, and then went home, and he came to the clinic once a week for follow-up. This is the immediate 1 week post-op from the halopelvic. You can see that his chest is quite straightened. His proximal thoracic curve is is less than it was before, and the patient is tolerating the traction well. So we kept him on traction for a long time, almost 3 months. This is after 2 weeks of traction. If you look and compare the preoperative versus the 2 weeks traction, you can now see the spine clearly in the coronal view, and in the sagittal view, it's obvious that proximal thoracic kyphosis is much better. And the patient was kept for 3 months in traction until we were able to see that his sagittal profile is nearly normal and his X-ray showing very good correction. At that point, we felt that we are ready now to move to the next step. So what should be the next step? Either growing instrumentation, growing rod, magic type of growth guidance, or definitive fusion. So since he's so young, so I would say definitive fusion is out of the question. Then we need some kind of growing instrumentation. And I was lucky to publish with Dr. Ala one of his papers about APC. I'm really convinced about it. And I think it's one step towards the ideal correction of EOS. So that's what we did. We did an APC, an apical control for him. So this is X-ray. So we did the 6 screws in the proximal thoracic to control it, and then an apical screw to control the deformity, and 2 and 4 screws in the distal foundation with a domino that is self-distracting, so the patient can be distracted spontaneously with time. This is the immediate post-op. As you can see, the stair strips on the back of the patient. We were quite happy with the correction. We felt it was an amazing correction. The patient and the family are quite amazed with the condition. But when dealing with difficult cases, it's never that easy. So this is his 1 month post follow-up in the visit. As you can see from the sagittal clinical photo, there is a slight link to develop a forward neck tilt. It's not much, but it is worse from the immediate post-op. If you can look at the X-ray, you will find that he's starting to develop a slight PGK. So his proximal area is starting to go forward. At this point, it was just radiological, no clinical symptoms, so we kept him under follow-up. But on the 3 months follow-up visit, it was a total PGF, proximal junctional failure. You can see now his chin to neck deformity, chin to chest deformity. He cannot really look forward because of the PGF. So at that point, this 3 months follow-up, we had to do something. So thinking about the possible option, we thought about doing traction again. How far do we need to extend for fusion, and how to protect our proximal foundation. So concerning traction, we thought that this is a fairly recent deformity, so we didn't thought that it's going to need traction. Extension of fusion, we went to the first lordotic vertebra, which at this point was C5. So this is what we did. We used a freehand with fluoroscopy to put pedicle screws up to C5. And then, because we were afraid that these screws are so small for his age, we're going to pull out, we put the patient in Minerva cast, which he tolerated not bad. And this is the 2 weeks post-op. And also we did a little bit of under correction of the proximal thoracic curve, so that not to put a lot of stress over those tiny screws. So this is the 2 weeks post-op. This is 3 months post-op. So the patient has now to somewhat controlled coronal deformity. The sagittal deformity is in the near normal sagittal contour. However, as I said earlier, this is never the end with treating in such cases. So if I look forward, so this is 6 month follow-up. So what happened here, we had a breakage of one of the rods at the junction between the 3.5 to 5.5 rod, where it's a little bit of a weak area, but the other rod was holding. So coronally and sagittally is still okay, nothing can change, but that looks like it's going to break in the near future. So we had a consultation with the family. They were not keen on doing a revision surgery at that point, so we kept him under close follow-up. 4 months later, he came with this picture. So if you look at this picture on the coronal clinical photo, you can see that this rod is starting to be under the skin, starting to push the skin. His neck is starting to tilt forward. It's not failure yet, but there is a little bit of pull-out. Radiologically, on this side, you can see the broken rod from the left X-ray. But what is different today, this sign, is those screws that are holding her neck are starting to pull out. The whole construct is pulled out a little bit. It's not fully pulled out, but it is starting to pull. So that is going to fail sooner or later. So as I said in the beginning of the presentation, this is a still unresolved catastrophe. So the patient is scheduled for surgery next week. And I took the advantage of this nice gathering of surgeons to ask for suggestions to what is the best option for this patient. Thank you.
Great presentation. And I think APC and apical control techniques in general, I know are increasingly being presented at conferences here, but are a really great thing to talk about when chatting about this sort of surgery in lower resource settings. And I'm not sure if anyone else is familiar with Sheila, Vertiglide, those sort of things have really gained traction in the US. And I think it can be quite helpful for kids with short stature, kids that can't regularly follow up and that sort of thing. Um, I'm interested to hear from anyone on the panel, seeing as the revision surgery is quickly approaching, what they would do to address the proximal pullout.
So it's scheduled for next Tuesday, this Tuesday.
So there's time to cancel still. As you point out, that's an unbelievably challenging case. And I think when you look at this apical control techniques, they work a lot better when you have a, say, thoracolumbar hemivertebra or a complex deformity, and you have a lot of room to glide on both sides. One of the tricky things, if you look at those are size-wise a pretty large rods for that child's side, and you almost were a victim of you did too well with his kyphosis correction. And I think one of the things that we find at the end of a construct, if you're going to stay out of the cervical spine, if you overcorrect that proximal thoracic kyphosis, the spine just wants to go back. And so I think, your x-rays look terrific, and this is super challenging. And I think your traction setup was amazing because there are people I'm sure would have considered a high thoracic VCR for a knuckle like that, right? But very risky. I think at this point, every time I've had a patient where one rod looks funny and I say, well, I'll just wait a little longer, I always wish I had done something earlier. And so sometimes maybe bullying the parents a little bit into giving them the worst case scenario. But I think where you are now, it wouldn't be a terrible thing to try to, maybe take out that other rod, put the child in some traction, try to see if you can get a better correction, and then, give a little time, you can re-instrument. And I would consider something anteriorly as well in the cervical spine. If you have a good experience with that or a good surgeon access with a thoracic surgeon, you sometimes can get quite low and span the cervical junction. Because otherwise, I think this is just going to be a battle that you're going to be fighting for a long time.
This is the sternum here. Like you can see, it's quite high.
Yeah.
I wouldn't think, So would you think if I change this rod to a smaller rod and did a connector lower than here, so that will be a little bit less prominent and it will hold a little bit, and then change these screws with a bigger screws and like do the same construct with a little bit of less correction, would it hold?
I think it could. I think there's a mismatch between the strength of the rods and the child's spine. The other thing, and I've had this with neurofibromatosis patients, when I do my transition, if I put it at the same level, my rods break. If I can somehow stagger it a little bit, so the same, so your two transition rods end to this. So I don't remember who gave me that tip, but it was a obviously pretty wise person who learned the hard way also. So I think that's another, thing that you can do that sometimes will shield the rods from failing at the same level.
Okay, yeah, that's a good idea.
Could I ask?
Well,
Sorry, Abba. Please go ahead.
I might suggest something. Of course, I know the case. Yahya have presented it before, and it's really a challenging case. And I had a couple of cases who are exactly like that, 4 or 5 years having very osteoporotic bone, and whatever you would do, most probably you'll have proximal junctional kyphosis. And I would suggest that you need to control it as much as possible for some time until it settles down. And I think you need to maybe to change just the rod and put a halo vest. And the halo vest can be for months so as to control it and settle it down until everything will settle. And it's, I think, a very safe procedure. And you don't need to go to complicated surgeries or very hard choices afterwards.
Okay, that's a
Assalamu
good
alaikum.
idea.
Assalamu alaikum.
Wa alaikum salam, Dr. Abdullah.
Hello, doctor. Yes. Yeah, how are you? Dr.
Alhamdulillah.
Allah, how are you?
Yeah,
Nice to see you here.
wallah.
Nice to see you
Nice
here.
to see you always.
Yes, mashallah. Yes, I think I endorse the option by Dr. Allah that keep it in the Hello Vest, because you can't keep a Hello Pelvic for a long time, not more than 6 months, 7 months. And if this patient might need a Hello Vest for more than 1 year or 2 years. So Hello West, you can have some modification in that, and you can have some patient some time away from that, and sometime you can apply that, and it is a better option. And you can exchange these rods with the newer one. And the option by Doctor just mentioned that the transition point should not be at the same time, same point. Should be different from both the rods. It adds to stability. And for initial at the start, you did fusion early, and then you remove that halo pelvic. I think when you applied this initial rods, you should keep that halo pelvis for more than 2 to 3 months after initial surgery. It was better. It was better
So
to
you
have
wanted to keep the halo pelvic after the surgery?
after the first surgery for 6 to 8 months, just to have some external support as well, so that whole of the burden should not be bear by the implant only. So that it leads some yes, it will need some fibrosis and even some yes.
Do you do the surgery with the halo
you will
on?
do the surgery, and you will keep the halo pelvic for more than 6 to 8 months after initial surgery.
How do you position the patient with the halo? Because it's very hard to put the patient prone with the pelvic pins coming out.
I have done more than 100 patients with halo with surgery. We are used to do that. We put some kind of pillows, and we adjust a patient with halo. I usually routinely do definitive surgery in halo. And after when I put all the screws, do all the dissections, all the osteotomies, then while manipulating these rods, turning the rod, rotating the rod, then I remove the halo ring at the skull side only, just to have some place for spine to rotate and spine to move. And after final fusion, then I remove the halo. In all the cases, but in cases with some slight small kids, I have one case which I did fixation of these cervical spine patient was having C1, C2 instability, 5 years of age, and I did cervico-hospital fusion there, and then I keep that patient for 8 weeks, 8 to 10 weeks after that surgery. After that surgery, 8 to 10 weeks for halo pelvic, and then I removed that and then applied halo pelvic, then Philadelphia collar for that, and patient went very well. So I think it should have been a routine practice for such kind of patients, such kids. You can put these devices even after surgery. It will make it will save your efforts.
Okay, so I understand. So you will keep the halo, and when you're putting the rod, then they will detach the halo from the head, and then
yes,
after putting the rod, you'll put it back.
You will put it back. Okay. Even sometimes while you're putting endotracheal tube, we routinely remove this halo ring, disconnect that from the rods, put the endotracheal tube because while putting endotracheal tube, you need to flex the neck, extend the neck. So you cannot extend the neck in this halo. So we need to remove that, just to disengage that, put endotracheal, then reattach again. Because when you remove halo, it collapses, the spine collapse. So I used to routinely do with this halo pelvic all the surgery. Okay.
I hate to jump in and be the bad guy here. This is a fantastic conversation, but just for the purposes of time for the other two case presenters, I think we should probably start thinking about moving on. But really excellent learning points here. Maybe Yahia, some last comments before we transition to the next speaker? Yahia, what are you planning? What's your plan for Tuesday?
So my plan, I'm going to change this rod, but rather to make the connection here, I will try to put a connector here. So I'll put 135 rod long here, so it will, and then I'm going to put it in under correction so that the patient is not fully corrected, so that doesn't have a lot of stresses. And I'll do the same side. I will change those screws that are pulled out with the same length with a thicker diameter, and then put another long rod 3.5 with a connector down here. But I'll make sure that the connectors are not at the same level, and the cervico-thoracic junction has no connection over it. Hopefully it will hold. And then probably I could add a halo vest if available.
I do like the idea that was brought up about the halo pelvic vest. The halo vest, I mean, that's a really nice idea. Yeah, Prof. Ujwal, if you want to share a comment, and then Yahia, if you can stop sharing your slides and Fahim can begin his as we transition. Prof. Ujwal, please go ahead.
Yeah, it's a very difficult and one of the most interesting cases I've seen. And these cases, as we have little experience, found at 5 years of age, the spine is more rigid than the other normal 5-year-olds. And if the kyphoscoliosis segment around 3 to 4 vertebrae, which I have seen in the initial X-ray and the CT scan, I would like to review and go back to the patient as it started the treatment. Whether everyone would agree, there's a role of kyphectomy here, a couple of vertebrae removed and then do the growth rod. And would that have helped reducing the PGK in the long run? I'm just putting these questions to our faculty.
I think in the 5 year of age with a lot of comorbidities and pulmonary function reserves are very poor. You cannot go with the vertebrectomy of 2 level or more level because it was almost 180-degree curve. You cannot have only 1 level vertebrectomy and correction for that. You need about more than 2 to 3 vertebrae. And with 5 year age or these reserves, a patient cannot tolerate for that. So non-fusion technique is always better for like such kind of pathology. So, however, you can have some after you have corrected this with halopelvic. Then at that time, you can have minimal fusion at the apex. You can go sideways and do 2-level dissectomies and do posterior fusion. Posterior fusion from posterior side, posterior fusion, and at the apex, you fuse 2 to 3 segments without any resection of any segment. That will be an option for, and if you have to control this deformity. Another option for that is there. I think, but vertebrectomy or tooth level CR is not for this kind of patient at this age.
Thank you guys so much for those comments. We'll move on to the next presentation now. Keep all of that for the next one.
Fahim, can you please share your slides?
I think they were up before, but we can't see your screen right now. Awesome.
Can you see my screen now?
Yes, but I can see. Okay, now we can see your slides.
Okay, wonderful. Good morning and good afternoon from wherever you have joined us. And my name is Dr. Mohammed Fahim. There was a bit of mistake, and I'm not a resident. I'm a consultant orthopedic surgeon working in Gurki Trust Teaching Hospital, Lahore. And I'll be presenting a case. I have the disclaimer is I have nothing to disclose, and I work in Gurki Trust Teaching Hospital under the leadership of Professor Amir Aziz. And recently, we have developed into a university as well. So my case discussion would go along a case of a patient female presented to us at 10 years age, described as early onset scoliosis initially, height of 91 centimeter with a weight of 20 kgs. These are the clinical pictures of the initial presentation. Any thoughts from the audience? I think we see a lot of these cases in our part of the world, might not be very prevalent in the Western population because these cases tend to be picked up very early. But she presented to us at an age of 10 years with no prior medical intervention. And her deformity was initially observed by a mother 4 years back. But then again, she did not receive any proper treatment. She now comes to us with a spinal deformity and limping gait. And she has recently developed some breathing issues in exertion especially. So how to proceed. This for the residents and the people out there. Initially, every patient that we come across, we have to do an X-rays. And nowadays, the EOS X-rays are more prevalent in the Western world, less so in our part of the world. But a standard AP and lateral X-ray is the routine which you can get. And if you see this patient, you see that she has a major curve in the thoracolumbar region as well as in the thoracic region as well. And she has significant kyphotic deformity as well. And if you see particularly the right hip, it is dislocated. So we come across this patient, and just for a little bit of information, about I think 27% of the people around the world have DDH in scoliosis more than the normal population. And in the neuromuscular scoliosis, there's about 29.5% more chance of dislocation of hip as compared to other scoliosis as well. So if you see here, the pelvis is, the acetabulum is quite dysplastic with the head of the femur dislocated, and the pubic obliquity is also there, and the spinal curvature is also making the hip more prone to be dislocated. So measuring the Cobb angles, we see that the thoracolumbar curve is about 130 degrees, and the proximal thoracic, the thoracic, main thoracic is about 105 degrees. The patient has decreased T1 to T12 height. In these patients, one thing of note is that the minimum T1 to T12 height that you want is about at least 17 centimeter, 20 centimeter would be a good height. And then you will not be having the thoracic insufficiency syndromes. If you fuse or if the patient has a less T1 to T12 height, then she'll always be having the breathing issues. And now this patient has also developed them. If we see the left bending and the right bending X-rays, we see that both curves are structural and they're not significantly reducing. If we calculate the angles, so we can see on the right bending, the thoracic curves go to 85 and the thoracolumbar reduces to 90. One thing of note is that if you see in the last X-ray on the right of your screens, the traction X-rays is something that is correcting both of the curves. So moving on, is any further imaging or radiological workup required? So the answer to that would be absolutely yes. The typical dogma is if you get an early onset scoliosis of somebody that's less than 10 years old, with right left shoulder up, a left-sided curve, even in adolescence, foot abnormalities, asymmetrical abdominal reflex, anything that's out of the ordinary, you definitely need to go for a further workup, which includes an MRI, a CT scan, and so on. So we did the MRI for this patient, and what we see here is that in the dorsal lumbar spine, there's a spina bifida at the sacral level. And this would mean that this patient would be classified into a neuromuscular curves. If the early onset scoliosis, I was looking at the curriculum earlier, and there are new classifications which describe these early onset scoliosis in different kind of classifications, like congenital, idiopathic, and this would be termed into the neuromuscular along with the CPs as well. So in the neuromuscular curvature, there's a more chance of dislocation of hip, about 29.5% more chance as reported in literature. When we see the CT scan, we see that there's a significant kyphoscoliotic. However, there are no failure of segmentation or failure of formation. So the congenital scoliosis has been ruled out. So what are the treatment options? I think in the previous presentation, a little bit of what I'm going to present has been already shown, but now I'll show it when it actually does work and does not fail. So this is something that we do routinely in our setup. If you see, again, the x-rays, I want you to look at the rightmost x-rays. The curves are correcting in attraction. So this gives me some kind of assurance that if I apply some kind of traction device, I might get a good result out of it. And it might be something to think about. What we developed in our part of the world, initially, the halopelvic system was described by Mr. Leong from Hong Kong, and then developed in different parts of the world. What we modified it is by applying an Ilizarov assembly. So we apply the halopelvic with the halopelvic, like a pelvic external fixator shunts, and then we distract the spine slowly. So these are a few publications of this setup. And this is our halopelvic modified assembly. If you see clearly, the back is open and the patient is able to lie down, and in between both the rods, we leave the space for the patient to pull out their arms, so their normal day-to-day activities are not disrupted as much as compared to the halopelvic device, in which the patient will not be able to lie down. And even that is still better than the tedious one, the halofemoral ones, in which the patient has to remain in the hospital for 6 weeks. So with this assembly, we distract and 1 mm twice a day, and we can send the patient home, and then they can come back and be with us in regular routine follow-up. And we explain to them about the neuromuscular, the neurological complications, and we initially, during distraction, observe them as well. This is the halo component, similar to any halo component, but we have modified it to put 6 pins, and we want a robust traction device for that. This is the pelvic component, in which if you see, there's a pelvic external fixator assembly, but we applied the halopelvic device to it. And these are a few of our patients in the hospital wards. They're always lying around, and we have a special area where we keep these patients, so they are in constant contact with each other and give moral support to one another as well. So moving on, this was the patient that we initially were discussing, and we applied the halopelvic device. If you see, we applied only 1 chance on the right side of the patient because of the dislocated femoral head, and on the other side we applied 2 chance. And even if you see with the previous initial presentation, a significant correction has been achieved. One thing of note is that in this halopelvic device, the kyphosis tends to correct better than the coronal deformity. The sagittal deformities are, and especially the thoracic and the main thoracic ones are correct very nicely with these. And the patient was very happy. As you can see, she is smiling. These are her x-rays. If we quantify, and this is a video of her walking. So if you see, the device is a little bit heavy and she has that limb and she's not used to walking this device. It's a very early on video of her after the surgery. And after 2 months of halopelvic distraction, we normally apply halopelvic for 6 to 8 weeks with 1 mm distraction twice a day. And we keep the patient in regular follow-up and explain the neurological complications as well. And sometimes we keep them in hospital as well. So if you see, the kyphosis has significantly corrected. The coronal plane deformity has come down to up to 70 and 65 in thoracic. And now something, it's in range that we can do something better with this patient. So the next question is how to further proceed in a 10-year-old child, to fuse or not to fuse, the Shakespearean question. And we can look at the pros as well as the cons of both. So in the fusion, we can just fuse and the patient will not be able to further grow. One thing of note is that her thoracic T1 to T12 height is increased with this, but not significantly. So one thing that is something we have to consider if we want to do a fusion or not. So what are the options that are available? These are the growth guidance system technology, the Sheila and the modified Sheila, as you can see in the first picture, in which the apex is fused and then the rods are able to slide up from the topmost and the bottommost rods are not connected properly. So they can slide. Then there are distraction-based rod systems, the traditional or the magnetic ones, in which you can distract after a certain period of time, the vertebral body tethering as well. So all of these were not quite appropriate for our patients. So management of early onset scoliosis presents a difficult challenge in the pediatric spine surgery, and a short straight spine is no longer acceptable. The focus now is on guided growth of the spine with fusionless surgery until an acceptable curb angle and a maturity is achieved, which is followed by a fusion when the patient is old enough, and minimizing the spinal deformity while maximizing the thoracic volume. These are the main crux of the early onset scoliosis. So the optimal options are newer concepts emphasize on employing two or more of the above philosophies. Various combination of distraction-based system guided growth and compression-based approaches might be more suitable and biomechanically speaking, a more suitable surgical intervention. One such combination currently used for surgery includes the active apex correction, which was described in the previous case as well, and is in your curriculum available as well. And Professor Ala is the pioneer of that approach, and these are some of his publications and more to follow as well. So this is the final correction that we achieved for this patient, significantly better kyphosis and a thoracolumbar correction as well. One thing of note in that in APC, so we have an active apex correction. So first of all, we have to describe what an apex is. So the apex is basically 3 vertebrae and 2 discs. And in between the first and the third vertebra, you do a fusionless surgery. You just put two screws. You do a muscle splitting approach, land on the pedicle, and just put a pedicle screw in without any fusion. And then you compress the area so as to achieve a normal and a balanced or a rectangular disc as much as possible. And the aim is in order to allow the patient to grow, and then the disc will become more parallel. If you can see here, there were 2 major thoracic curves. So thoracic and thoracolumbar curve. So what we did was we applied the APC formula, but twice times over. Once, if you see here in the thoracic ones, we have modified or controlled the thoracic apex as well as the thoracolumbar apex as well, and applied the assembly in a modified way, and then the growth available and with time, and she will be able to grow. So this was our first challenge because the thoracic insufficiencies was impending on this patient, and the hip became secondary. And now after this, the hip is being managed as well. So these are the post-operative pictures of this patient or after the last follow-up. And if you see the scanogram, the hip is dislocated, and now she will pursue the hip surgery as well. Because if we don't pursue the hip surgery, the spinal obliquity and the spinal, there will always be pressure on the lower segments of the spine, and this will lead to degeneration and failure of our construct when we finally have to fuse as well. So the comparison of the initial presentation and the last follow-up, you can see there's a significant change, and there's some cases that this surgery has gone quite well, and we are following up this patient and until she has now achieved acceptable thoracic height, but we're still seeing if we can achieve a little bit more height before the final fusion of this patient. So in our experience, we do about 200 plus scoliosis and similar cases per year, and we started the ABC technique in 2022 and 2023, and this is our team, and thank you for allowing me to present. And I would like to thank again the SONA Forum for giving us the opportunity. And thank you again.
Thanks, Fahim. Do you mind keeping your slides up while we have a few questions and comments from the faculty? That would be great. Just for purposes of time, let's keep comments from faculty a little short so we can still get to Dr. Kojo's presentation. Any thoughts? Superb case, an excellent review of the workup process and everything, Fahim. Thank you so much for doing that for all of our trainees on the line.
So, can I comment?
Please.
Absolutely.
Yeah. Well, first of all, I'm really very happy to see APC how it's efficient, and it cannot be done except when we have excellent surgeons like surgeons in Egypt and in Pakistan. But the thing that I want to say is the importance here in these specially neglected cases of the non-surgical management preoperatively, how it can change your surgery and how can it be of benefit. Even with the case of Dr. Yahya previously, the halo traction gives great access to the success of your surgery in the future. And we need to concentrate on casting, halo traction, these kind of things as a process that will get the child from point A to point B as safe as possible. And we need to think that in early onset scoliosis, we don't need to have excellent result like the final fusion. All what you need to have as safe as possible, as less complication as possible to get the child to be until they have the spurt of growth going on. This is what comes to my mind.
I have a question, Dr. Fahim.
Yes.
With this patient's hip spine pathology, how are you thinking about whether or not to extend your fusion to the pelvis, and what sort of pushed you not to?
So, okay. So, good question. First of all, like Dr. Ala said, we are not fusing right now. We are just growth modulating. If you're a pediatric surgeon, you will understand the concept very well that if you modulate the growth and then we make her safely reach a point when we want to finally fuse, then we will decide. But I think by the time that we do get to the final operation, if you can see the final X-rays, we can avoid going into the pelvis, and that I think will be a very good option for her. And another thing is that before that, we have to look at her hip as well, because we want to, if you see the clinical photos, so there's still a little bit of a lumbar lordosis. Initially, when she presented to us, there was an excessive lumbar lordosis and still present because of the dislocated hip. So first of all, we have to treat with that. And since her triradiate cartilage is closed, so we'll probably do a double or triple pelvic osteotomy, or probably a periacetabular osteotomy, get her spine in place, and then modulate her growth and follow her up until she reaches a safe age. And then at that time, we will decide if we want to extend to the pelvis or not, and then we will be in a better position to do that.
Thank you.
Assalamu
Doctor.
alaikum. Yes, let me add to that. Because we have two discs in between the pelvis and the lumbar spine, we have quite flexible lumbar spine here, and there is no significant pelvic obliquity. So I think there's no need to go to pelvis. If you go to pelvis and then all the stresses will be on that hip, it will get early degeneration. So no need to go to pelvis. It is normal almost when you have surgery for the pelvis, that hip, it will be all okay, inshallah. Thank you.
Thank you.
Another point to add is that it basically is growth modulation, and none of the spine is fused, and there's still space for us to work. So this is the important concept in APC, that you don't fuse the spine. It's a fusionless surgery. And then when you, at the end of her growth cycle, we will discuss whether to fuse and what levels you want to fuse.
What's your timing for doing the hip?
So initially, hip should be done early, but because she presented with a thoracic insufficiency, so that was our priority. And now, after a significant good follow-up period, so now we are looking to do the hip as well. So
And how long
as
is
soon
that
as
after
possible.
how long after your last surgery will you do the hip?
So after about 4 to 6 months.
Gotcha. Thanks. Just for the purposes of time, let's move on to our last presentation. If the faculty are okay staying a bit longer, I would really appreciate it, because I think Dr. Kojo's presentation is fantastic. So thank you, Fahim, Dr. Fahim. That was phenomenal. Really great presentation.
Thank
Really
you. It's been
appreciate
my
it.
pleasure. Thank you, everybody.
Yeah, thank you. Dr. Kojo, do you mind sharing your slides and you can give your final presentation for the group?
All right. Thanks very much for having me. And I think I've learned a lot. This is the first time I'm listening to the program. I've really learned a lot. I share a case of congenital kyphoscoliosis, was managed with hello gravity traction and the magic growing rods. Okay, so this is okay. So this patient is currently 9 years old. We saw her when she was about age 1, that's somewhere 2017. The parent had noticed a deformity when she was about 6 months old. Generally, the pregnancy had been uneventful. She is the third child of both parents. The older siblings were doing very well. She delivered by cesarean section. No, the deformity wasn't noticed when she was pregnant by ultrasound. There's no family history of spine deformity. In general, her developmental milestones had been up to date. At the time we saw her, she was 1, her weight was appropriate, about 10 kilograms, her height was appropriate for her age. And she was quite a very active child, moving all the limbs. She had an obvious deformity at the back. These were her clinical photo, the x-rays at the time we saw. So she had a double curve in the thoracic and thoracolumbar region. She was a little hyperkyphotic. We asked her to do some investigations, but she thought the child was too young and didn't want any intervention very early. So she couldn't do the CT and then the MRI requested for. And then she also sought alternate ways of managing the child, that's the parents. So we saw her again a little later when she was about 3 years old. By then, the deformity had worsened, especially the kyphosis. The kyphosis had worsened to about 68 degrees. At that point in time, we discussed the use of growing rods with the parents, but then they still wanted to try alternate ways of managing her. But we still continue to follow up until much later on, somewhere 2023. Okay, these are the clinical photos when we saw her 2022. So she had a significant kyphosis at the back. And that's 2022 when we saw her. So 2022, she was around from age 5 age 5. And then these were her CT scans. So essentially, CT, she had multiple hemivertebrae. Let me just show yes. Okay, so she had multiple hemivertebrae, many in the lower thoracic region, about 3 of them. And then again, the lower thoracic towards L1, she also had another hemivertebrae over there. The main deformity was the kyphosis. We did an MRI for her, but there was nothing within the spine, no Chiari, no tetraene of the cord, no other intraspinal abnormalities. And then when we scanned her for echo to check for other congenital abnormalities, all these things were absent. The only thing she had then was that she had a limb length. Sorry, let me just go back a bit. Okay, so by the time she came to us 2020, we had noticed that she had a limb length discrepancy. The difference was about 2 centimeters. And then she had a little bit of a varus deformity involving that limb. Okay, but at that time, the deformity was getting worse, so they had agreed to have surgery. And that's 2022. And then once you agree to have surgery, then you have to try and look for funds for this surgery. Most patients have to pay out of pocket, so it took quite a bit of time for them to raise funds. So that's somewhere 2023. The kyphosis was then about 93 degrees by the time they had agreed to have surgery. And then she had a scoli both in the main thoracic and then the thoracolumbar region. But at this time, we thought the kyphosis was quite significant. And to put in growing rods at this time would be, we cannot mobilize the apex of the deformity. So we opted to put her in halo gravity traction for a while, get some correction of the deformity before doing the growing rods for her. Okay, so she was quite not flexible. From 93 hyperextension views, the curve only improved to about 85 degrees. She had good pulmonary function, for the type of deformity that she had. So this is our halo gravity traction setup. So we put them, whether they are sitting, lying down, or walking around, we have devices where they use for their halo gravity traction. So we did halo gravity traction for her. This is a pre-op, and then we did traction for about 8 weeks, and this shows the clinical photos. Okay, so that's the back, and we've got some significant improvements with the kyphotic deformity. Okay. So in terms of the angles we had, the scoli itself didn't improve probably as much as we wanted, from about 64 degrees to about 55 by 8 weeks in traction. However, we had gotten quite significant improvement with the kyphotic deformity from 93 degrees to about 64 degrees. At this point in time, we thought we could go ahead and then put in our growing rods for her. Okay, so that's her in theater. And then that's with the growing rods. We use magical growing rods. This is 6 weeks after 6 weeks after surgery. And then this is 6 weeks. So we had gotten very good correction of the kyphosis. Scoli, we couldn't control that bit very well. So she still had some scoliosis, but not too out of proportion. And then that's 6 months after surgery. She's been coming for lengthening. So every 3 months, they come around for us to lengthen. And she's been doing that since 2023. Okay, so this is at her last review this year. These are the clinical photos. And I think we are happy with the extent of correction and her growth so far. She's currently 9 years old. The plan is to continue to lengthen her till probably for another couple of years. When we are satisfied with the growth she's had, we can go on to do a final fusion for her. Okay, so these are the last x-rays that she did. Thank you very much.
Thanks, Dr. Kojo. Can you go back to the initial x-rays and images so that we can discuss them? Any comments from the faculty?
Yes.
Okay.
Thank you, Doctor.
Sure.
Thank you for giving us this wonderful case. But one thing I want to ask, when the child came and you have talked to the family about the choice when she was 3 years of age of having a growing rod, why didn't you think about casting before that? So as at least to buy some time until she grows a little bit more. Casting under GA.
Okay, thanks very much for your question. So by the time she came to us at age 3, really the cutoff for doing growing rods for us is like age 2. If your weight is good, more than 10 kg. Well, casting is an option, but I must say this patient, the parents were quite reluctant to, matter of fact, even first have surgery. So I agree, we could have done casting, but a lot of the time it's uncomfortable for some of the patients. And we didn't mention casting, but they were really not too keen about having surgery. Our option for them was for us to do growing rods for her. And this is also congenital. Sometimes, well, you get some control, but it may not be the best. Yeah. So this is at the time when she was about 3 years old. Yeah.
have a question that I think would help a lot of the trainees from different locations on the call as well. How do you decide with these patients um, who you'll treat with traditional growing rods versus magic rods versus something like an APC Shilla technique? They obviously all have their own pros and cons in terms of need for return to the OR, frequency of follow-up appointments. Is there a preferred technique at Focus, or do you try to accommodate more, the patient's family and what you think they're capable of in terms of follow-up?
All right. Oh, I can go on. All right. So in the past, I think we've gone through all these series with the traditional growing rods. This girl is like 3 or 5 years old by the time you are doing traditional growing. That means almost every 6 months you go back to theater. And even if you do that twice a year, you wait till the child gets to age even 11 or 10. That's multiple surgeries. And sometimes the return, especially when you've done it a number of times, the return you get on the lengthening is not that good. So we've moved away from traditional green rods. We've also done cases where we've controlled the apex of the deformity, but we found that most of the time, if the curve is not too big, then you tend to get very good correction, or you're able to maintain the correction that you get at surgery. But ever since we got started using magic rods, we found them quite useful. And we don't have to go to theater very often like we used to do in the past.
I'm curious, maybe the other panelists have experience, or Dr. Everson can provide a perspective here. It's been my observation over the last few years, even in residency alone, that we've really moved away from magic rods to some extent because of some of the complications with metallosis and difficulty converting to a fusion. Obviously, they provide a lot of benefit in terms of, being able to do clinic follow-ups and lengthenings instead of intraoperative. I'm curious if that's been the same experience abroad, or if, kind of weighing the pros and cons, it's still more worth it to go with magic rods.
Yeah, Laura, I think you're right. A lot of us were excited, but then became somewhat frustrated with difficulty lengthening. And the tricky part in this case, and I'm curious how you achieve this, is the straight section of the magic rod can't be contoured, so it's particularly challenging for kyphosis. And you got a good correction, but not a perfect correction from your traction. But then you look at your intraoperative alignment, it actually looks quite good. So did you seat the proximal screws first and then use almost a cantilever technique to anchor your inferior fixation points?
Exactly, that's what we did. So
Yeah.
we continue to do so intra-op. We do the traction. So if let's say the person was on, so we still do intra-op traction as much as possible, and then make sure that keeping into consideration the neuromonitoring status of the patient. So, but we put in the rods proximal, put in the proximal screws, and then try and do some cantilever, and then fix the fix the distal part of the rod onto the screws. Yes, yeah. But I think the main thing is that the proximal fixation must be very strong. If they are not strong, they will pull out. And so on some occasions, you've had to use like 3 screws proximally instead of 2.
Yeah, it's a very good result. I always use the 5 proximal anchors rule. It seems to lower your pull out. It's also, for the magic rod, for a kyphotic deformity, distraction can sometimes be challenging. So it's interesting the way you've contoured the rods there, and I think that should hold up. I guess a bigger question is, if families are paying, how do you handle that situation? Because if they're trying to raise money for the surgery, these are far more expensive than other options.
Sure. So I must say, majority of the patients here actually pay for their surgeries. However, the hospital has also a foundation, and we try and raise money for patients who cannot pay. And then, yeah, we have a number of partners who also support us. So like these magic rods were donated by the San Diego Spine Foundation. So they don't have to pay for that, yes. But they pay for the other things. We try and subsidize this for patients, but we can't do for everybody. Yeah.
It's a very nice result.
Okay.
Ujwal, did you have a comment?
Oh, I think you're on mute.
Thank you very much for such a nice presentation from Focus Hospital. And well, it's a good correction and it's a very nice result for this young girl. But I have a question about the congenital hemivertebrae 2 levels. What are you doing to that? If you would like to excise it at some stage to get a better correction of the spinal deformity, or you just leave it around because this might cause problem over a period of time. Once you remove the magic rods, when the growth is over, the hemivertebrae, these 2 hemivertebrae that you have around this segment, they may cause a lot of trouble. So what would be your take on that?
Okay. So really on the CT, in the apex of the skull, it's about actually 3. And then when you come to the lower thoracic or lumbar, there's also another hemivertebrae. Okay, it's on this side. Yeah. So that I agree gives us a lot of challenge. But I think the one which seems to be putting her more into kyphosis is the one in the lower thoracic region. And that at the time we are doing final surgery or final fusion, we'll aim at taking it out.
Yeah, that would be my take on the case. So thank you very much.
Thank you.
We are about 10 minutes over time, which I think is fine because the conversation has been phenomenal. But maybe we could wrap up with some final comments from the faculty on this extraordinary case. Allah, would you like to maybe lead us with final comments?
Yeah. Well, a final comment about the general issue is that, first of all, there is no consensus about any specific surgical management that can be the optimum one. Still, we don't know, and all what we are doing is trying to have mechanical correction. Still, there is metabolic and genetic factors that we don't know much about. The other thing is that all what we need to do is just to get the child from point A to point B until after the spurt of growth in the most safe way and the least burden on the child and on the family. So because of that, for example, on the first case, I wouldn't go for osteotomy to correct the whatever pelvic oblique is still there now. You need to do that afterwards when the child can be adjusted and can be finalized. And for the other surgeries, for example, the importance of the preoperative management of casting or traction might give you a chance to do just one surgery until the child becomes 12 or something like that. And this is our aim. It's not full correction or having final issue. So this is what I'm talking. This is my comment.
Craig, any final comments from you? And maybe Zenaida, if you don't mind, could we pull up the final closing thoughts slides?
Yeah, I thought those are 4 outstanding cases, and I think this highlights with early onset scoliosis the need to kind of not have just one hammer and use everything as a nail. There are a lot of things that work, and you have to individualize the treatment. And I think traction if you can have patients in the hospital and monitor them in halo gravity traction, that works tremendously well. But I think we've also seen that having halo pelvic traction could be an option when that's not possible. But setting yourself up for success by getting the higher level imaging and using casting and traction and other techniques to try to maximize your chances at a good outcome, are important. And we can see that the complication rate for things like kyphosis and junctional kyphosis and implant failures are very commonplace in these surgeries. So kind of knowing that and setting up your first procedure with what am I going to do next and what am I going to do next, and trying to minimize the number of procedures until you can get to a fusion is really key for these kids.
1 second. We're just pulling up our closing slides. If any other faculty have any other comments.
Yeah, maybe Prof. Abdullah, did you have any comments to just close out our session? Thanks, Craig. Those were great teaching points. Great way of summarizing the lessons from these cases. I learned a lot. Yeah, Prof. Abdullah, any comments? Can you unmute?
Assalamu alaikum. Yes, first I thank to all the organizers for having such wonderful gathering and discussions. There are a lot of variety of cases starting from syndromic, congenital, and then various kinds of procedures adopted. And the common thing was halo traction, halo pelvic or halo gravity or something like that. So again, as I said already, that there are a lot of options available for these kind of patients. You just need to sort out which is better for in your hands, which you can do safely, and what requirements, circumstances which allow you to have. We have options for magic rods, but it is too costly for especially people for like in third countries. So we have option of APC. It is gaining worldwide acceptance, and thanks to Dr. Ala for having such nice invention for that. I have also done these cases with APC, more than 50 cases, almost 50, between 50 to 60 cases, and I have data of more than 2 years of more than 20 patients. I'm going to present a paper on NC-COT and as well as in the global spine on APC technique as well. So it is a very nice technique. We should also have our armamentarian for that. And also, again, thanks to organizers for such nice, wonderful, knowledgeable meeting. We should have these meetings off and on to build up our knowledge and share our experiences. Thanks.
Thank you. Prof. Ujwal, yes, please go ahead, Ujwal. You're muted.
It's been an excellent discussion about all the seriously challenging cases by the presenters from around the world, and it's significant thoughts have been provoked about what kind of surgeries or what kind of complications and what kind of thought process towards these growing children with such deformities, and which one is the correct one. We are still in the evaluation process. For example, the multiple problems faced by the patient with the early onset scoliosis with a severe sagittal loss of balance after surgeries and an extension into the cervical region with a PJK. So that's a very significant problem. And in children with such deformities are very uh, much forbearing for the surgeon as well as the patients and the families. So in my little experience, I think that I would not go into such details of the surgery with them in the very onset, but we'll just observe them over a period of time that like everybody has done, how the curve is behaving. So the behavior of the curve is very important. And once we know that we have a definitive answer after discussing with our fellows who are involved in this type of surgeries, then we can proceed and think about not having a complication which brings your life, my surgeon's life by 10%, you know. So that's an important message. I think I would have it for myself and take it further. I look forward to such, you know, organizing such a meeting once again. I would be very much happy to be a part of it. Thank you.
Thanks, Ujwal. It was a pleasure to have you. Any comments from our case presenters? Dr. Kojo, Dr. Yahia, Dr. Fahim, Dr. Matthias?
I want to say thanks very much for the opportunity. Managing early onset scoliosis is always a big challenge, and Thank you for the opportunity to share ideas. Thank you.
Thank you, Kojo. I think, there are so many interesting things that were very unique to this cohort of case presenters
I
that
would
were
like
brought up.
to, I would also like to say something that thank you for the Sona team and for arranging the seminar. And we saw a lot of different cases, and the key takeaway points from this is that everything works, but you have to choose the right technique which suits you, and you have to have the right armamentarium. And I think these cases are very challenging, and a conventional approach sometimes does not work. So always think out of the box. And I think there's a lot of still innovation to be done in these cases as compared to the adolescent in which everything is almost set. So the early onset is the new place where new innovations need to be there as well. Thank you.
Thank you, Fahim. And I think there were lots of wonderful suggestions on how to deal with the resource limited setting, which was really unique to these case presentations and very much appreciated. Any other comments from Dr. Yahia, Dr. Mateus before we wrap up?
I'd like to thank you, everyone, for the discussion. I learned a lot today, and that's it. Thanks so much.
Thanks, Mateus. All right. Well, I guess with that, Yahia, are you there? Did you want to say anything? All right. Well, with that, Zenaida, why don't you take us to the end here? Thank you all so much. Really phenomenal presentations and discussion.
Yes, I'm very grateful for all of you guys for tuning in on a Saturday from everywhere you guys are. Thank you again. We can move on to the next slide. As a reminder, we do have a certificate of participation. You just have to make sure you complete this post-session survey. We'll also be sending out an email with this QR code if you guys are unable to get it now, and we'll plan on giving out the certificates at the course conclusion. And just like this week, we have a lot of materials on the SONA Global Academy site, very helpful. A bunch of videos. I would really encourage you guys to check those out if you haven't already. They're very helpful. And if you have any concerns, any questions, any comments, please send us an email. And please, as a reminder, to complete the post-session survey. We look forward to seeing you all next week. We'll be talking about spine imaging trauma. And so let us know if you have any questions. Thank you for joining.
Thank you all so much. We can leave the slide up just for people to scan the survey code. And just want to say one final thank you to all of the faculty and the case presenters. And Zenaida, Laura, thank you so much.
Thank you, Kieran. No other comments?